Good evening and welcome to another edition of Health Plus Weekly. Thanks for tuning in. My name is Maureen Boyle. I'm the Public Information Officer at Southcoast Health. Tonight we are finishing our three-part series on the Southcoast Health Weight Loss Center. We will be spending the first half hour asking our surgeons anything. So we invite our viewers at home to send us your question, and we're going to do our best to have our surgeons answer them within the time frame of the show. For that, we welcome back Dr. Rayford Kruger, Chief of Surgery. Thanks for coming back, Dr. Kruger.
My pleasure. Thanks for having me tonight, Maureen.
And we are also going to have Dr. Rachel Cimaomo on set. Thank you very much for being here.
Thanks for having me.
Great. Our second portion of the program tonight, we will be talking with Dr. Jessica Inwood to discuss medically supervised weight loss and available medications for the treatment of obesity. I'd also like to introduce my co-host and social media extraordinaire who will be managing the Facebook comments tonight.
Thanks, Maureen, and thank you to our guests, and thank you for joining us this evening once again. We are taking questions, as always. You can ask these fine physicians and surgeons anything you'd like, and we will do our best to pass those questions on to them during the show. Let us know where you're from and start asking your questions, and we look forward to tonight's show.
Great. Thank you so much, Shawn. So we'll dive right in. Dr. Kruger, tell me, give me a little bit of the history of the program and your history within that.
Absolutely. So the bariatric or weight loss surgery program at Southcoast is a full comprehensive program for surgical weight loss that we started in 2004. For 15 years now, we've been treating patients in the South Coast, Cape and Islands region who desire to have weight loss surgery. And as we've discussed in prior shows, weight loss surgery is indicated for patients who have about 100 pounds of excess body weight or body mass indexes greater than 35 or 40, depending on what medical conditions they have. Now, our program has been quite successful and grown tremendously over the last 15 years. We now represent one of the largest weight loss programs in all of New England, serving almost 700 patients a year for weight loss surgery. And when we look back over the last 15 years, we've operated on 7,500 patients, which by our calculation means that about 600,000 pounds of excess weight has been lost in the South Coast region in our patients over the last 15 years. One of the nice things about weight loss surgery is the comprehensive team approach that we and other programs have, though we're very blessed to have a great team of psychologists, dietitians, social workers, nurse practitioners, all working in one group with one coordinated effort, with surgeries in the program working out of two hospitals, our hospital at Toby Hospital in Wareham, and then also our Charlton Hospital as well. And we have offices in both Fall River and Wareham that serve our patients.
Great, thank you so much. So tell me a little bit, what is the advantage to having all these services under one roof? What is unique about the South Coast program?
Well, weight loss surgery in general is more than just the surgery. In fact, the surgery is a very small portion of what really becomes a programmatic approach to help patients with a lifestyle change that includes education and processes for change around their relationship with food, education about healthy eating and healthy lifestyle. And all of that is encouraged through a 4-month pre-op process where they are evaluated by dietitians and get one-on-one counseling. They're evaluated by our psychologists to help with lifestyle change, and then even have some group classes to get them ready for that. But having a coordinated program with practitioners that this is 100% of what they do, all working together with a team, is much better than having it sort of piecemealed or farmed out to various people that may not be doing weight loss surgery as their specialty. Our team's been together for 15 years, and many of our nurse practitioners, dietitians, and social workers have been with the program the whole time. And they've really developed a great program and a great level of experience in not only helping patients get ready for surgery, but supporting patients post-operatively. And we're committed to offering follow-up office visits and post-op support groups to all of our patients in multiple communities across southeastern Massachusetts.
Great. Tell me a little bit about your history with the program.
Well, I started the program back in 2004 after doing a significant amount of education and research and learning through multiple programs throughout the country. And we started off fairly slowly. It was about 100 cases our first year. But as patients began to respect that they could get the care locally and that it was as good as in Boston, and then we were able to show that actually for a convenience standpoint it was better, it became more popular and we added more surgeons, Dr. Streeter, Dr. Colaccio, and then more recently Dr. Cimaomo and her colleagues, Dr. Wacko and Dr. Fay. So we've now rounded it out to 6 fellowship-trained bariatric surgeons that do these procedures in addition to general surgery in our 2 communities.
Great. Bariatrics is an area of medicine that has evolved over time. One thing that comes to mind is the use of a lap band. Can you kind of tell me where medicine has come in those 15 years?
Well, I think you're right. Weight loss surgery or bariatric surgery 20 years ago to 30 years ago was done with big, large incisions. You were in the hospital 6 or 7 days, and there was about a 3% mortality rate. Now, over the last 10 to 15 years, our procedures have changed to become laparoscopic procedures. So much like open gallbladder versus laparoscopic gallbladder, for the bariatric procedures, these are all now done laparoscopically, which means patients recover much more rapidly. They're generally in the hospital 1 or 2 nights and back to full activity in 2 weeks. The other thing that's changed is we used to do primarily Roux-en-Y gastric bypasses. There was a period that the lap band came along and was felt to be a less invasive procedure, but the success rate of the lap band really wasn't where we wanted it to be. And the sleeve gastrectomy, where we now shrink the stomach down, has become our most popular procedure, with about 80% of our procedures being done that way. With the volume of procedures we've done, with the experience not only our surgeons have gotten, but other programs in the country, we have really put this down to a point that the risk of having a weight loss surgical procedure in our facility and others is very similar to having gallbladder surgery or an appendectomy, meaning they're very routine procedures that are relatively safe with very few complications. A lot of that is the skill set of our surgeons and the advances in some of the stapling techniques that we have, but it's also with a team of great experience that's done it a lot and has gotten very good at it.
Great. So 15 years, you're hitting a milestone this year, and there's something special going on.
We're very excited about our 15-year mark, 7,500 patients, and we plan to have a patient reunion on June 1st at our Rosebrook site. And if you go to our website, southcoast.org/weight-loss, there'll be information for all of our patients that want to come, and please bring a friend or anyone else that might be interested in weight loss surgery. We're going to have the surgeons will be there. There will be booths. Some of our team that may have taken care from you in the hospital will be there, and we've really enjoyed seeing patients come back and have bragging rights for how successful they've been, and also it allows the team to see the changes we've had in many people's lives.
I'm sure it's very satisfying to see that all the time. All right, so Dr. Cimaomo, welcome to the program. Really, welcome to the program and the program.
Thanks, I'm glad to be here.
Great. So tell us a little bit about yourself, where you're from, and your role in the Southcoast Weight Loss Center.
So I came to Southcoast going on 5 years ago. Basically, I came here straight out of my fellowship training in advanced laparoscopic surgery, like bariatric weight loss surgery and other advanced laparoscopic procedures. And basically came straight into this program, just really excited to join such a great and well-developed program.
Great, excellent. So let's jump right into it. Let's start with you. Can you kind of get into what the criteria for what is the criteria for a candidate for bariatric surgery?
Right, so Dr. Kruger touched on it a little bit. Basically, the official criteria for it is a BMI or body mass index of greater than 40 or greater than 35 in certain circumstances. Now, I don't really expect anybody really to know what their BMI is off the top of their heads, because that's not really how general public works. So most people, if they can think to themselves, man, I could really stand to lose about 100 pounds, that's usually an indicator that they're probably somewhere in that range. Right. I did mention that there's kind of 2 different criteria. One is a BMI over 40 just by itself. The other is a BMI between 35 and 40 when there's other medical problems already present. Things that we know go along with being that overweight, things like sleep apnea, diabetes, and uncontrolled high blood pressure. those we know are helped by the surgery. And so when those are already present, even at those lower weights, between that BMI of 35 and 40, then we do know that surgery is more of a benefit in those patients as well, and not waiting until they're, the BMI over 40 in those cases.
Shawn, I believe we have something from the Facebook feed.
We do. We have several questions, actually.
Oh, wow.
I think-
Already.
I think folks know this is the third and final part of our trilogy, so they're trying to get all their questions in tonight. We've got one here from Mattapoisett. Some say surgery isn't necessary and that all anyone needs to do is eat healthy and exercise. Can you explain why it's not always that simple and why a program like this is so important to so many?
I'd be happy to do that. So basically, when you're 100 pounds over your ideal body weight, there is a lot of things conspiring against you. And we have a lot of scientific information now to suggest that there are multiple hormones, both around feedback of satiety and hunger, hormones that help regulate insulin and other body hormones that are often disrupted in patients that are morbidly obese. There are even some scientific evidence that suggests that there may be a regulatory mechanism that's off, much like people have thyroids that manipulate metabolism and temperature regulation. There may be a weight regulation that's off. And so I think it's very hard for a person at 100 pounds over one's ideal body weight, just dieting and exercise alone, to get to a weight that's 100 pounds less. Surgery is a tool. It's not designed to replace healthy eating and healthy lifestyle, but it is a tool to be used in combination that helps reset the body's mechanisms for weight regulation, and also helps reset some of the things that are out of balance with hunger and satiety, such that it becomes easier for the patient to lose the weight through earlier satiety due to the small stomach that a bypass or a sleeve might offer, and then also to maintain that weight and stick with that program through the hormonal changes that we've documented that happen around decreased ghrelin levels, which cause hunger, and then also manipulations in insulin metabolism that help with fat stores and weight gain. So these are metabolic operations that actually act like many medications that we can use to help block and rearrange to assist a patient in losing what is generally an insurmountable amount of weight if one is just trying to do it with diet and exercise alone. We'll hear a little bit more later in the program about non-surgical mechanisms that we use with some of the newer medications that are out. But quite frankly, the results of medication versus surgery, we reserve surgery for those people with these high excessive amounts of weight that need to be lost because of the amount of it takes to get that much weight off.
I would just add there that it's really important to reframe our thinking around obesity. Obesity in and of itself is a disease, just like diabetes is a disease. And there are certain circumstances where treating diabetes with diet and behavioral modifications is enough to help keep that at bay. But when it gets out of control, insulin and oral medications are the only real treatment, and diet alone is not going to be enough to treat that disease. Obesity is no different. A mild kind of dysregulation in that weight control center in our central nervous system might be able to be treated adequately with some dietary and behavior modifications. But when it gets as out of whack as being over 100 pounds overweight, at that point, those mechanisms really need a hard reset. And typically those diet and behavioral modifications just aren't enough.
You were saying?
Sorry, my phone decided to chime in on that.
You know, we also know that there are a lot of people out there that think surgery is the drastic way out or the risky way out. And I think that we really need to put in perspective that for someone who's diabetic, has sleep apnea, has hypertension, and is 100 pounds overweight, the medical risks at that level are not zero. They are significant. And that a surgical procedure with the safety profile of less than a 0.1% mortality rate, meaning that it's one of the safest procedures that we do, can result in within 6 months to a year, 100 pounds lost, resolution or dramatic improvement of diabetes, hypertension, or sleep apnea, and scientific data to show that a 9 times reduction in mortality rate occurs in those patients. It's a very little risk for a huge amount of benefit when you look at people that are having morbid obesity and the associated complications.
Yeah, those numbers really speak volumes. Do you have one more there, Shawn?
I do. I think we sufficiently covered that question. Thank you very much. As you can see, when you ask your
We're a little
questions,
passionate.
We have great resources
yeah,
here. So.
when you ask these questions, they will seriously be answered. So I have a shout out here from Tammy, who says, I had the sleeve 14 months ago, down 150 pounds, best decision, I've ever made. And speaking of the sleeve, we have Krista who asks, it seems the sleeve has replaced the lap band. Any new technologies on the horizon that could potentially replace the sleeve?
I'll let Rachel grab that one.
All right.
There's always lots of things out there that we're investigating. We're always trying to figure out how to be less invasive, less change to the abdominal and GI tract to be able to try and get the same benefits. Some of those are foreign devices. Some of them are changes in the technique, how big we should make the sleeve, how small we should make the sleeve. If we're doing the bypass, how long we should make certain portions of the bowel and the reconnection. And so most of the studies are kind of on the fine tuning at the moment, and then some new devices that are coming out. What we know with most of the new devices that are coming out, things like balloons that go in the stomach to kind of block and treat give that sensation of fullness quicker without actually having to alter the stomach in any way. We know that they have the same problems that the band had. They cause issues because it's a foreign body that's in there and can cause problems. And they're a lot more temporary. They have to come out after a period of time. So it's a lot more temporary benefit because eventually it has to come out.
Great, thank you. Dr. Kruger, what is the best starting place for a patient considering our program?
It's very easy now. Our program has a couple ways to enter it. On our website, southcoast.org/weight loss, there actually is a patient seminar video that you can watch in the comfort of your own home and then contact our office for an appointment with a surgeon. We also offer free seminars that are run by our surgeons, and those seminars are held in Hyannis, Wareham, New Bedford, and Fall River. And by contacting either through the website or our office, which the number's at the website, you can sign up for a seminar. Come in with yourself or your family and meet our physicians and hear a 45-minute presentation about the pros and cons of weight loss surgery and the different procedures that we do.
What are the frequent questions you hear in these seminars?
Well, one of them is what procedures are actually available, and I think that though we touched on, there's very little out there that's about to come in and replace our 2 standard procedures. The laparoscopic Roux-en-Y gastric bypass, which we've done all 15 years and is somewhat of a long-standing gold standard, and the sleeve gastrectomy, which quite frankly in the last 10 years has become a very popular and successful weight loss operation. You'll see on our website a description of the 2 procedures, but the nicety of the sleeve is that essentially we remove 3/4 of the stomach and leave a banana-shaped tube without manipulating the intestines. And I think for lay people, that's very easy to understand. We shrunk your stomach. Mm-hmm. And when we shrink your stomach, the material that we remove actually is where the hunger hormone ghrelin is secreted. Mm-hmm. So you tend to be less hungry, you get full faster, and you lose weight without moving and manipulating intestines. And I think that has some benefits in that long term. We see less complications with ulcers and bowel obstructions, and even some of the vitamin deficiency issues that we ran into with the bypass we don't see as often with the sleeve. And we now do that about 80% of the time.
Great. Dr. Cimaomo, let's talk about pre-op a little bit. Sure. So how does a patient prepare for surgery? Is there a variation between procedure?
It's essentially the same for both procedures. It basically starts out with kind of getting the information. So coming to one of our informational seminars or watching our video online just to get a little bit more information about what it is that we're talking about, watching some of those videos, because it's really a lot better to visualize what's going on when we're going to do the surgery. And then the first step from in our office standpoint is a meeting with myself or one of our partners to discuss a patient's medical problems, what medications they're on, what surgeries they've had, to determine what their weight is, what their BMI is, and go through all of that together to determine, is there a surgery from our standpoint that would be more beneficial for them? Are they about equivalent for them? Or is there anything in their surgical or medical history that would limit our ability to do one versus the other? And then move forward from there. After that, it's basically going through the system and meeting with all of those other portions of the team, like Dr. Kruger talked about earlier, that are luckily all under the same roof, our nutritionists, to evaluate not only what their relationship is with food from a nutritional standpoint currently, but how is that going to change, and start preparing them for that change for after surgery. As well as some meetings with our psychology staff to meet with the emotional, to talk about the emotional relationship that they have with food and how is that going to change after surgery, and start preparing them from that standpoint. And then there is some medical clearance that we have to do. We work with some of our pulmonologists and cardiologists in the community here to have them really evaluated to make sure we optimize them from a medical standpoint so that we can make it as safe as we have for them to undergo anesthesia and make it as safe as we possibly can. And then the other nice part about our program is we have a group session that everybody has to go through that's basically a behavioral tips and tricks workshop of all of the things that we have learned over the last 15 years of doing this, and all of the things that we want you to know to try and keep you from having to go over those hurdles. Right. And learn from other people's mistakes, to be perfectly honest. Yeah. So that you can try and avoid them yourself.
Great. So walk me through what maybe, a patient got their surgery date. What is the day of like for a patient?
Well, I think it's a very exciting day for the patients. Many of them think of it as their new birthday.
That's great.
And they've spent months preparing for the surgery. They come into our pre-op area. They have an IV started. They meet with our anesthesiologist, and they come back into the surgical procedure room. The procedures under general anesthesia take roughly 30 minutes to an hour. Our patients go to the recovery room where they'll spend about 2 hours waking up from their anesthetic. Then they go up to our surgical floor. And shortly after arriving at the surgical floor, they're generally out of bed, walking the hallway, recovering from their anesthesia, staying mobile. And the following morning, they start on a they get water first thing, small frequent sips. Lunchtime, they get clear liquids. By the evening time, they're on a full liquid, which is protein shakes, carnation-instant breakfast, stuff like that. The following morning, they're discharged home. So 2 nights in the hospital, you go home on that full liquid diet, and you'll remain on that for approximately 2 weeks. Then the diet progresses to soft food, scrambled eggs, mashed potato, yogurts, ground beef, stuff like that. And that usually lasts for another 4 weeks before we progress on to regular food.
And you recommend 2 weeks out of work.
We generally ask our patients to consider 2 weeks and plan 2 weeks. We certainly have a lot of people that go back at 1 week, but I think it's always best to plan 2 weeks, and I would say that's our average. Laborers, things like that, sometimes it's 3 or 4 weeks. We've had office people and nurses go back at 1 week, so it's very, very patient dependent. 2 weeks is a good average. And again, that's very similar to what we recommend in gallbladder surgery or appendix surgery. These are laparoscopic procedures without big incisions.
Excellent. Dr. Cimaomo, walk me through what the healing process is like.
So, like Dr. Kruger's talking about, basically it's small incisions. The healing up from the external standpoint is very, very quick. Those tiny little incisions, they're up walking around the night of surgery, getting moving. And then from an internal standpoint, it's really about getting that stomach to heal up well enough, which is why that's kind of slow advancement of the diet, just sticking with just the liquids for that first 2 weeks to really allow that area where we've cut the stomach to heal really well before introducing those solid foods into that area.
All right, great. Shawn, do we have anything on the Facebook feed?
We have a lot of stuff on the Facebook feed. Let's see here. We've got a question about any excess skin afterward. is that there's not much to the question. What about all that excess skin?
Well, it's a very common question, so
Yes,
not
it
surprising
is.
that you see it. It's generally more common with the patients preoperatively, questioning what's going to happen with all this excess skin. And I would say 90% of the patients, that's their question pre-op. Interestingly, post-op, a lot of patients are not bothered by the excess skin. Some, however, do have significant amounts and can get rashes and problems related to it. I would say about 10 or 20% of our patients actually have issues with excess skin post-surgery and choose to go on. I think insurance companies are beginning to recognize more the health benefits of weight loss surgery and start to treat the excessive problems with excess skin as medical conditions and not put them in the cosmetic category. We still have some insurers that do put them in the cosmetic category, which then means the copays and fees for patients are a bit higher. In general, the health benefits of these operations far exceed the issues with excess skin, and the majority of our patients are not complaining or having issues with excess skin. But there are many patients that, the 100, 150 pound losses that could benefit, and some do have options through their insurance. Some choose to do it on their own financially. Some choose to just live with their excess skin, and they're perfectly happy to be healthier and more active.
Great.
Great, thank you.
Awesome. Thank you so much. I think maybe this probably crosses almost every patient's mind is what are the risks associated with surgery? Either
So I
procedure.
think the surgical risk are, as I've kind of emphasized it multiple times, I think the public's perception of the risk of weight loss surgery far exceeds the risk. We have reduced these surgeries down to the level of complications of any routine surgical procedure. So there's nothing different in the risk level of having a sleeve or a bypass in our facilities than if you were having a gallbladder surgery or an appendectomy or a hernia repair. The risk profiles on these procedures are now incredibly low. What are the things that can happen? Leak is one of the things that we worry about. We're dividing tissue, putting tissue together, stapling tissue. Our leak rates are now less than 1 in 1,000. They're very, very infrequent. Bleeding to require a transfusion is also very, very infrequent, about 1%. There are many operations that we do are much higher than that, but this procedure, it's very unlikely. Blood clots, also incredibly infrequent, but with like any surgical procedure, there's a risk that you can develop blood clots. I'm going to emphasize again, 95 to 99% of the patients that go through these procedures go home as expected without significant complications.
That's great. Dr. Cimaomo, tell me about the relationship with the patient. How many times do you see the patient before, and then what is the relationship post-op?
Yeah, so for the surgeon's meeting with the patient before surgery, it's usually 2 to 3 times. The initial surgery and one definitely right before the surgery within about 30 days prior to that surgery. And then occasionally we do need to meet once or twice more in case there's anything that comes up during the medical workup or anything that we need to refine our plan for the day of surgery. After surgery, we know that the first year after surgery is going to be the time where they go through the most changes, have the most weight loss. That's where we're going to need to be monitoring them as much as possible for any nutritional deficiencies and making sure they're staying on top of their fluid intake and their protein intake and getting in the nutrition that they need. So we see them very frequently during that first year after surgery. Basically, at 1 week we see them. At 2 weeks the nutritionists see them. At 6 weeks we see them again, and then basically after there it's like every 3 months until things are a little bit more stabilized at about the 1 to 2 year mark, and then we start seeing them once a year just for our annual kind of touch up, make sure the blood work's looking okay, make sure their vitamin levels are good, and then any time in between if they're having any issues that they're worried about their food intake or anything going on, they're always encouraged to call to come in and be seen sooner.
So it's a very close relationship.
Yes, it is.
One thing, this is an elective surgery. So is this covered by a lot of insurances? What are people's options?
We're very blessed in Massachusetts that most of the major insurers, Blue Cross and Blue Shield of Massachusetts, Harvard Pilgrim, Medicare, Medicaid, United, generally all accept the positive benefits of weight loss surgery and cover it, including Mass Health, BMC, Neighborhood Health. The elective nature of the surgery is many of the insurers do require that we submit prior authorization information about a patient's diet attempts, their education preoperatively, and their medical clearance. But like I said, we're very fortunate that in Massachusetts, most insurers cover. We occasionally run into difficulty with patients that have out-of-state insurances. For instance, if you work for Coca-Cola, your Blue Cross is going to come from Atlanta. If you work for an employer that's stationed outside. And every state has different guidelines. Again, we're very fortunate in Mass that most people are covered by insurance with minimal out-of-pocket expense.
Probably speaks to just the overall benefit of the surgery.
I think it's been well recognized in this area, and people have, the insurers have been supportive of it.
Great. So before we go to a break, I have a question for both of you. So what is the most important piece of advice you tell your patients?
I guess I'll start with that one. What I do like to tell my patients is that weight loss surgery is still just a tool. It's a power tool instead of a hammer and nail in our journey for weight loss. And it needs to be used in conjunction with those other tools. But it's still a tool that we can use, and it makes sense to utilize all the tools that we have available to us.
Great. Dr. Kruger?
Again, many of our patients come to us after having failed 6, 7, 10 diets, and they really question, is this really going to work? And I would echo what Dr. Cimaomo said. This isn't a magic pill. It's not a magic bullet, but it is a significant tool that will work, that will help you be successful. But your success will be much more likely if you use this tool in conjunction with the behavior changes, lifestyle changes that we encourage you to learn about and follow postoperatively. And if you remain in contact with our program and work with our post-op support system, those are the patients that generally do very well and are very happy with the result.
Great. Thank you very much. So we're going to take a quick break, but before we take a quick break, we are going to do a myth versus reality. Shawn, would you like to do the honors?
That's right. We've got another myth versus reality for everyone watching tonight. Please give us your answer in the comments if you can. It's a true or false, as always. Bariatric surgeries can only be performed once. True or false? Again, that's bariatric surgeries can only be performed once. If you want to answer in the comments, when we come back, we'll have the scoop from our physicians and surgeons. So thank you very much.
So we have 3 programs available that are non-surgical options for weight loss at Southcoast for patients who are either not interested in surgery or are not candidates for surgical weight loss. 2 of the programs use meal replacements, which are the OptiFast products, and then the third option is the 3Cs program, which is an all food-based plan. So if someone's interested in the program, we have them come in for an in-office consultation, and we can go over their medical history and their eating habits, and we can talk about what program would be a good fit for them.
I would have a shake for breakfast and a piece of fruit, and a shake for lunch and a piece of fruit, and then I would eat a healthy dinner, because I'd have to provide dinner for my family anyway.
The benefit of using meal replacements for weight loss is that they're calorie controlled and they're portion controlled, and it takes some of the thinking and planning out of what am I going to eat today. So it makes it very convenient for people to follow a calorie restricted diet, which is necessary for weight loss.
I needed something that wasn't complicated. Who wants to get up at 5:30 in the morning to make yourself like some eggs and vegetables and stuff like that? I think it's helpful that is the weekly appointment and you know you're going to get weighed in. And I think what they teach you in the class, it's really helpful, you know, how to look at a nutrition label, how to navigate going out to dinner.
Our program offers educational classes each week that are taught by registered dietitians and our psychology team that help people change their eating habits and also learn about why they might have certain habits and help them to change those habits. Once people complete the programs, they can still come to the classes for the group support.
I still attend the classes, and the support of the other people in the classroom was really helpful because you weren't doing it alone. I've lost about 47 pounds now, just having that weight off my body. I've been able to exercise more. Mentally, I feel clearer. Physically, I feel fantastic because I've worked exercise into my lifestyle, which was something that I was hesitant to do. I've tried new things, like with my family. So we went skiing last year and it was miserable. And then this year I went skiing and it was fantastic. We had a wonderful day.
So this program is good for anyone with any weight-related medical issues such as diabetes, heart disease. The program can be done in coordination with their primary care doctor and with the medical supervision of our medical director. We have the program at 3 different Southcoast locations. We offer the programs in Fall River, Dartmouth, and Wareham. Whenever people are ready to enroll, we have open enrollment so people can join in at any time.
You do it because you want to do it for your health. The feel-good part of it, it's worth to do for yourself. The looking good part of it is just the extra bonus.
Welcome back. If you're just tuning in, we are concluding our 3-part series on the Southcoast Health Weight Loss Center. We have with us tonight we have Dr. Kruger, Dr. Cimaomo, and Dr. Inwood later in the show. And before the break, we had a myth versus reality with the question, the true or false question, bariatric surgeries can only be performed once. And we have a lot of falses, a lot of trues in the comments. It's pretty evenly split, so we are going to consult the professionals.
A trick question is the answer. So for the Roux-en-Y gastric bypass, generally a Roux-en-Y gastric bypass is done once, and same with the sleeve gastrectomy. If there is an anatomic problem with your bypass or sleeve, and we should find that in a follow-up study, such as some people that had bypasses 15, 20 years ago, their pouches might be abnormally large. Some people who might have had a sleeve 10 years ago, maybe the sleeve was too large. There may be options to revise those, so that's revisional surgery. The one other caveat, if you had a lap band before, we do convert lap bands to sleeves or bypass for patients who have had inadequate weight loss. And we often do that as one procedure. Remove the band and do the secondary bypass or sleeve procedure at that time. So there's a case where you would be redoing a bariatric surgery. And in the sleeve gastrectomy, it's rare, but there are occasional times that we will convert a sleeve gastrectomy to a Roux-en-Y gastric bypass for inadequate weight loss. But let me emphasize one thing, and that is for all conditions where we consider revisional surgery or we consider a conversion of a sleeve to a bypass, the first 3 revisions in that process are at the nutrition's office and the psychology, behavioral therapy. Because with any kind of surgical modification, there usually needs to be a reinforcement of the healthy lifestyle, healthy eating process, and reimplant those behavior modifications. Because again, as we've said before, surgery is a tool, but with that tool, we have to have the nutritional and lifestyle buy-in, or we're really not going to get where we want to be.
Great, thank you so much.
Thanks.
So for everyone at home, I'd like to introduce Dr. Jessica Inwood. Thank you so much for being here.
Thank you for having me.
I've heard glowing things about you. So tell us a little bit about yourself and how long you've been with the program.
Okay. I have been practicing as a primary care family physician for Southcoast since 2007. And I joined the Center for Weight Loss a year ago after Dr. Kruger gave me a call to discuss a case and said, by the way, we could use your skills. 2 years ago, I became board certified in obesity medicine after practicing obesity medicine within my primary care practice for several years. After becoming board certified in obesity medicine, I had other primary care doctors referring to me within my office, and it was some of the most fun stuff that I would treat all day long.
So it really was like you found a passion for it, really.
I certainly did, yes. So when this position came up, I couldn't turn it down, and now I'm a consultant on more complicated and some of the simple obesity medicine cases as well. Every doctor has their own comfort level, and primary care, having worked as a primary care physician, I know that a lot of health problems have to be addressed in a short period of time, 15 minutes, and obesity is at the center of so many of these health problems, but we don't give our primary care doctors enough time to actually address it adequately.
Right.
So I'm here as a resource for them. If they want their patient to meet with someone monthly, have more time to just focus on the underlying disease that may be causing all their other diseases.
I see. So you, your area is medically assisted weight loss.
Correct.
And the use of medication. So kind of give me an idea of the scope of what you do as in your specialty.
Okay, so when someone is sent for a consultation, the first visit is 30 minutes. I look through their medical history, see if there are certain triggers that may have made them gain weight, psychological triggers, life events. There are certain points in time like puberty, menopause,
Right.
Pregnancy, where especially women will
Right.
gain weight because of hormonal changes.
And it can be a big dramatic change too for some women too.
Absolutely.
Yeah.
And so we talk a lot about that. I take a look at their medication list because there are medications that we use for lots of different diseases that actually cause weight gain. So if you're on 4 different medications that cause weight gain, even a little bit, they start to accumulate.
Right.
So if there's a way to get people off of medication, it's not just about prescribing meds, it's about deprescribing meds that they may not need anymore,
Right.
That can help them shed some pounds. And then I take a look at the different medications that are available for weight loss and try to determine what's going to be the most effective based on what the patient is telling me and their
Right.
past history. Some patients have come in already having tried medications, so if they were effective before, we might try them again. If they weren't effective, we're not going to waste our time.
Right. So tell me what your patient population is like. What is the criteria for medically supervised weight loss? So how does someone go from primary care to you?
Okay, so the primary care physician can refer a patient, but we do also have patients that cold call the office and say, I calculated my BMI and it's 30. I don't want to ever get to a point where I may need to have surgery. So I actually use a lower cutoff for BMI than the surgeons. Medication is indicated for a BMI of 30 or a BMI of 27 with a comorbid condition. So that's diabetes,
Okay.
fatty liver, hypertension, sleep apnea, and probably about 200 others. So the population that I take care of may not be at as severe an overweight state.
Right.
But there are patients that I'm seeing that have BMIs of 40, 50, that are headed for surgery but need to lose weight to reduce their risk
Gotcha.
during surgery. And then there's a population of patients who may have had surgery, say, 5 or 10 years ago, and they're starting to regain and they don't want it to get out of control.
Right.
So they come to see me so that it doesn't get too far along.
Excellent. So let's talk a little bit about what medications are available. There's a couple of different kind of areas they focus in, correct?
Correct. So there are 6 medications FDA approved for weight loss, and then there are off-label medications that induce weight loss but aren't approved for that purpose.
Okay.
Some of the medications that we use now most of them have some effect on the brain.
Okay.
Okay, because that is where everything is controlled.
That's where it starts.
That is where it starts. One set deals with addiction. So there's a part of the brain called the striatum that is where dopamine works. And dopamine is a feel-good hormone.
Okay.
And in someone who has addictive type potential, their dopamine system isn't working properly.
Right.
So I do ask a history of drug, alcohol, family history of drug and alcohol use.
Right.
Sometimes a patient will come in and say, I am addicted to sugar. I am addicted to a certain kind of food. And you find that within the family, there's all sorts of different addictions. So there's some genetic component to it. And some of the medications have overlap with being used for smoking cessation or alcohol cessation, and they'll also work for food addiction.
That's very interesting. Do we have anything from the Facebook feed?
We do. We have a steady parade of questions and comments. And one of those comments is from Tricia. She says, "Hey, Dr. Inwood, congrats on your new position."
Thanks, Tricia.
We have a question from Rodney, who says he had the gastric bypass surgery done about a decade ago and has gained back upward of 25 to 50 pounds. What can he do to get back on track?
Okay.
And that's for any of you guys.
So it's very common for weight loss patients to gain a small amount of weight back over a period of time, especially 10 years. But what we generally do when we have those patients is we have them back to meet with our dietitians and also to get back in our support groups. But for many of them, we'll often ask for Dr. Inwood's help in helping those patients achieve a healthier lifestyle. And sometimes some of the medications that she uses to help blunt, depending on the amount of their weight regain, to help blunt some of their triggers of hunger and help them get that 20 or 30 pounds back off to feel better. And that's where I can't say enough about having an obesity medicine specialist join our team and have the option of having a medical specialist work with the surgeons to not only get those patients that need to lose weight preoperatively in the right place, but then also for patients like this postoperatively. We also, for people that have lost touch with our program for a while, might check their anatomy and make sure their bypass or sleeve is okay. Most of the time it is. Most of the time these are lifestyle behavioral changes. 10 years later, people get a little bit off the routine. We try and reset the routine, and in some cases turn to Dr. Inwood to help reset some of the biochemical markers and blunt the hunger a little bit.
Great.
Dr. Inwood, did you want to mention anything?
Any of these medications that are used to control hunger can be used in postoperative patients. It's just a matter of trying to find the right medication. And at this point, we don't have a test that will tell you which of these meds is going to work. So it's very much a trial and error. And if the first thing we try doesn't work, then the important thing, the most important thing that I tell my patients is not to give up. We try one thing, if it doesn't work, try the next thing. You have to be vigilant about this.
Great. So you had mentioned that one set of medication sort of deals with addiction and where that lives in the brain. Mm-hmm. Can you tell me a little bit about the set of medications that deal with kind of boosting the metabolism?
Okay, so those are the stimulants, and those are actually a pretty old category of drugs. Those were the first weight loss drugs that were out there 60 years ago, fen-phen, which was pulled from the market, but I talk about it every single day because a lot of patients will come in and they responded great to fen-phen. Fen-phen had 2 meds in it. One of those medications caused heart valve abnormalities.
It's a tough one to say. It's just tough to say.
The other half of it was fine, and it's still on the market, and it's dirt cheap, and it's effective for a lot of patients. So we still prescribe that medication. Mm-hmm. That works in the brain as well, stimulating a neurotransmitter called norepinephrine that is like a get up and go kind of.
Jazzes you up.
It does. The stimulants are very similar to the medications we give children with attention deficit disorder. So if you know kids with ADHD, they take their Concerta or their Adderall, and they're not hungry. So it works essentially the same way. It also works not just in the brain, but peripherally in the fat stores to help release fats from storage. But these are no joke. These have side effects, and we have to weigh the benefit and the risk of the side effects.
Right. Do you feel like maybe that some of your patients are concerned, maybe they have misconceptions about, when I think fen-phen or when I think things like Trimspy, that's another one that was very popular maybe 10 years ago or so. Do you think that your patients have a misconception about what these medications are like or how they're going to be impacted by them?
I think as long as they're well informed, and we go through the entire list of what to look out for, that they're being monitored every month, There are cases of people being on these medications for years and years and decades, and we need to start looking at obesity as a chronic disease, not a moral failing, not something to be ashamed of. We treat diabetes, we treat hypertension, we treat obesity. It's another disease that deserves to be taken seriously.
Right. So can these medications be used in tandem at all? Does that ever occur?
Yes, we will very often start either one medication at a time, or there are a few that are used to attack this from different angles.
Gotcha.
Very often someone will start a medication, lose weight, and then plateau. The plateau is a real phenomenon. It happens to just about everybody. And if somebody's not at their own personal goal, we have an option to add on a drug from a different category to get them over the hump.
Right. So it's that time in the program where we're going to do another myth versus reality. The myth versus reality is obesity is a metabolic disorder that can be triggered by lifestyle. True or false? And we'll give it about 15 seconds. What do we got coming in on the feed? Anybody biting yet?
Well, I just put out a last call for questions because we've only got a few minutes to go. Here's a question from Mattapoisett. I saw a story about a new pill called Plenity that you take before you eat, and it turns into gel blobs in your stomach that make you feel half full. Is that a med you would possibly include in the program, Dr.
That's a very specific question.
It is a very specific, and it is a very timely question because that article just came out. It was just FDA approved. Plenity is not actually considered a medication. It's given in pill form, but it's considered a medical device.
Interesting.
And it kind of has the same effect that fiber does in the stomach. It expands, takes up space, makes you feel like you're full. I haven't prescribed it yet because that was literally, I want to say yesterday that the article came out.
That person is on their game.
Really up to date. This is great. But I would consider it. I just need to get more information. Yeah.
Great. So let's go back to our myth versus reality. Obesity is a metabolic disorder that can be triggered by lifestyle. True or false?
Oh, absolutely true. Yes. Okay, so metabolic disorders refer to an imbalance of either hormones or neurotransmitters in the body. And what we put into our body helps to either release those hormones or suppress those hormones. So if you're eating a lot of sugar, your body has to put out more insulin to metabolize that sugar. And insulin is one of the hormones that increases fat storage. So you absolutely have some control, but genetics play a huge part in this. So trying to attack things from all different angles is very important. And if you have a genetic predisposition to weight gain, the earlier you intervene, the better. We want to try to intervene when people are very young, get kids eating less sugar. The environment.
Because the level of the metabolism, so as you age, the metabolism changes, correct?
Correct. And with all these different milestones.
Compounding factors.
The longer you carry the weight, the harder it is to get the weight off.
Right.
So the earlier I get people, I mean, we're an adult program, but I have a handful of older teenagers because some of the medications can be used in that population. But that's not to say that some of my oldest patients are some of the biggest success stories.
Great. So obesity is a chronic disorder. What common misconceptions do people have about seeking weight loss medication or getting treatment for obesity? What's kind of the main themes you see in our society when it comes to the treatment of obesity?
Yeah, so many patients come in saying, well, I just thought I could do this on my own. And what does that really mean? Like, coming in to seek help that is a big step. Yeah. And they should be proud that they're seeking help for a medical condition.
Right.
I think people think it should be as easy. If someone has lost weight really easily, they have all the answers. And I think that it should be just as easy for anyone else. Just eat less and move more. That calories in, calories out theory is incomplete. Calories mean something, portion size means something, but you can feed the same foods to two different people and they're going to metabolize them differently and store them differently.
Mm-hmm.
So, it's not just as simple as we used to think.
Right. And these medications you've been referring to, they are safe, correct?
So every medication has risks.
Okay.
And I go through the entire list of possible risks with everybody, and you have to weigh the benefit versus the risks. I see very few, luckily, complications with the medications, and these are meant to be long-term. We don't say we treat someone's high blood pressure and we give them medication, we get their blood pressure to goal. We don't then pull the medication away.
Right.
That's what controls the condition. So if you're going to go down the route of taking medication for weight loss, it's a long-term commitment.
Mm-hmm. And is there opportunity to come off the medication or to switch medication? Is that something if a patient feels a certain way? So how does that come into play? What do you advise in those situations?
Right. So for most of these medications, if there are no complications and it's doing the job, there's not a reason to come off of them. If someone is eager to come off of them, we do it slowly. We do it and still monitor and see if we need to restart it or try something else. Obviously, if someone becomes pregnant or is trying to get pregnant, they can't be on these medications. A lot of them are very dangerous for pregnancies. Okay. So the right time to come off the medication, well, it depends on the person. Some people should probably be on medication forever. Mm-hmm.
And that's fine.
It is fine. And it's a very different way to think about obesity because we used to just think of it as, well, I just want a kickstart. I just want the medication for a short period of time. But this is a chronic disease. Even once someone has lost weight, it's very easy to put the weight back on. So as long as they're tolerating the medicine, there's no reason to come off.
Great. Thank you so much, Dr. Inwood. So we're just about creeping in on the end. I just wanted to make sure we're all good on the Facebook feed.
Oh, we're more than all good. We're great. Thanks everybody for taking part. Dr. Inwood, we have a note from Karen who claims to be your favorite patient. LOL. So we also have another comment calling Dr. Kruger the man of the year for changing so many lives. So
thanks.
Little did we know we were in the presence of celebrity. So that about catches us up.
Great, excellent. So before we sign off, Dr. Kruger, do you want to say anything else about the reunion coming up?
Well, absolutely. I think, first of all, thank you for having this in this three-part series.
Thank you
We very much appreciate it. I think we've had a chance to highlight not only our surgical weight loss program, multi-specialty, but also our medical weight loss with Dr. Inwood and then also our dietary team. And I think it's a nice balanced program for all levels of obesity to help people. In our 15 years, our reunion coming up June 1st, the details are on our website. Any patients that have been seen by us, please bring a friend or someone that might be interested and come join us on June 1st. We look forward to seeing everybody.
Great, thank you so much. Yep. So thank you folks at home for tuning in. Thank you doctors so much. These past 3 weeks have just been phenomenal. I've learned so much. And if you have more questions or you are interested in learning more, we do have the signups for the informational seminars on the website www.southcoast.org/weight-loss. And Shawn, would you do the honors of signing us off this evening?
I certainly will. Thanks to our guest, and thank you very much for watching tonight. If you have any additional questions or I missed your question on the feed, please message us through the Southcoast Health Facebook page. And have a great week.
I was motivated to seek surgery because both of my parents were raging diabetics. I didn't want that to happen to me, and I could see it coming. It was coming. I was getting older, and it took a couple of years of talking from my primary care physician, who kept suggesting weight loss surgery, and I kept saying, no, I can try Weight Watchers again. I can try Atkins again. Let me try this again. Let me try this, and nothing ever worked.
My life before my procedure was going down the hill. I was very bad diabetic, taking insulin twice a day with pills. My blood pressure was out of control. I couldn't walk 20 feet. I had bad sleep apnea. I was a couch potato. I didn't want to do anything. I really was having a hard time with life, period. Well, I started, my high weight was 375. And now I fluctuate anywhere from 192 to 200.
I started the weight loss program here at Southcoast in 2004. In 2004, the technology for weight loss surgery was changing from open procedures to minimally invasive laparoscopic procedures, dramatically changing the safety and recovery time for those procedures.
The breaking point for me to make the decision was actually talking to my doctor. I was having problems. I was, my breathing and a couple of things, my sugar and everything, my blood pressure. And they just said, you can't keep going like this. You're 62 years old. You just can't keep up this pace health-wise. You got to start doing stuff. And it just hit like somebody hit you with a sledgehammer. Now's the time to do what you have to do.
One of the advantages of the Southcoast weight loss surgery program is its commitment to long-term support. Again, our team of dietitians and behavior specialists do run multiple support groups monthly throughout the region to make it convenient for patients to stay in touch with the weight loss surgery program.
The support system is amazing. There's a support group every month, and you meet people doing the same thing you are. So in your regular life, as you're going along, the people who are always with you, maybe you don't want to go for a walk at 5 a.m. Ask somebody in a weight loss surgery support group. They're all looking for somebody to do stuff with. Everybody's journey is separate, but the paths are kind of parallel.
We educate our patients that the surgery is a tool that will allow you to lose significant weight over a short period of time of a year, but the lifestyle commitment and long-term support is necessary for long-term success.
I do a lot of things that I haven't done before. I do walk, I go to the gym. I'm faithfully at the gym all the time. But just stuff around the house. I cut the grass more now, where my wife was doing it. I work around the yard. I feel good. I have no stops.
Over the last 10 years, the transformation of weight loss surgery to being done minimally invasively or laparoscopically, much like gallbladder surgery now, has made the surgery now have risk along the lines of very common procedures such as hernia surgery and gallbladder surgery.
People suggest it and you think that your life is going to be over. I'm going to have this surgery, I'm never going to be able to eat, I'm never going to be able to do anything. And that's really not the case at all.
It's just the general health problems have disappeared. My heart doctor was amazed when I walked in. I'm like totally different. Blood pressure medicine's gone. He says, this isn't the same person. They laugh about it, I've changed my body so much. I have no problem telling people I had the surgery. I really don't, because I feel like $1 million. It changed my life.
Well, the successes for the Southcoast weight loss program have far surpassed anything we could have imagined. I think success number one is our patient satisfaction of having the services available locally, having a very well-respected, educated team caring for them, and having excellent outcomes, some of the best in the country.
I feel great. I'm active. I walk. I actually became a Zumba instructor. And it's like night and day. I don't watch hardly. If I watch an hour of TV a week now, that's it. It's always go.